Welcome to the Stat AI podcast.
Welcome to the future of emergency medicine, a realm where artificial intelligence isn't just a buzzword, but a beacon of hope and a tool for transformation. I'm DJ Apakama. My co-host Ethan Abbott and I are both emergency physicians, and we have witnessed firsthand the burgeoning role of AI in our field. Our everyday experience grappling with healthcare disparities and social challenges have led us to a pivotal question. In the wave of AI applications, what changes are coming to emergency medicine, and will they be for the better? This podcast was born not just to ask these critical questions, but to seek out answers from the experts, to understand and to demystify the potential of AI in emergency medicine. We believe in bringing this conversation to the wider community to embrace AI as a tool for positive change. This podcast is our exploration of that future, a journey we invite you to join. So let's embark on this path together to learn, to question, and to envision a new era of emergency medicine enhanced by the power of AI.
On this episode of the Stat AI podcast,
And I think we have missed the boat a little bit in emergency medicine and triage by not owning this a little bit more up front. But the first triage decision a patient makes is when they go to Google on their phone and Google their symptoms. And that's what 88% of sort of initial health queries go to Google. And putting a physician or a medical group in that place in the decision tree allows you to impact a patient's care in so many ways. We're really bullish on AI to help us have that kind of conversation, and broadly for AI to unlock the humanity in the patient-physician relationship. Not sort of like hide behind chatbots, but to unlock sort of experiences that we've never been able to have before to get closer to the heart of healthcare, which is really just a conversation between a patient and physician.
Hey DJ, how's it going?
Hey Ethan, how you doing?
I'm doing great. Today we have a paper, as we always do, try to discuss at least one paper on the podcast. This is a preprint from October 7th, 2024. It's from Archive. It took me a long time to figure out how to pronounce that. Hopefully I'm not the only person. Anyways, the title of the article is GSM Symbolic, Understanding the Limitations of Mathematical Reasoning in Large Language Models. And the lead author is Marzadeh, and I apologize for the pronunciation on that. And it's a group from Apple. Just a little sort of caveat, it's probably not as much in the emergency medicine wheelhouse as we've done in the past, but I think it does have important insights and applications to large language models and understanding their overall limitations. DJ, you want to talk about what the article discussed, and then we'll kind of go into a little bit of detail, but we obviously don't have time to do a deep dive on this.
Yeah, this is a 22-page paper, so I'm going to do my best to keep it kind of simple. Essentially, I'm going to use the analogy of a standardized test here. And so when you're thinking about how do we test large language models, how do we know which one is better than which and how they're performing, we're using some sort of standardized test. And one such test is called the Grade School Math 8K, or the GSM 8K, which is a data set that contains over 8,000 math school problems and their corresponding solutions. This is routinely used to kind of see how LLMs perform at mathematics. Problem with this is, just like with an actual standardized exam, won't tell you how smart an individual is, it'll tell you how well they studied for that exam. It's kind of what's going on here. So it's a fixed set of questions. There's risk for data contamination since it's a widely used set, and it's static. It doesn't change. So there is a slightly modified version of this data set called the GSM Symbolic, which, using symbolic templates, they're allowed to switch out variables and change the questions ever so slightly so that they are still kind of the same core content, but different. In addition to that, for this particular study, they added essentially irrelevant information to see if models could ignore that. And the whole point is to essentially see whether or not LLMs actually have logical reasoning or if they're just doing probabilistic matching. And so there's kind of several pieces that in this paper hint on the fact that, large language models may not actually be doing logical reasoning. And in fact, it seems like they're not. So the authors found that LLMs exhibit noticeable performance variation when responding to different versions of the same question in the GSM symbolic benchmark. For example, simply Altering the numerical values in the questions led to performance drops in all models tested, and sometimes as much as 65% in these frontier level models. So this is suggesting that LLMs are struggling to discern relevant information, likely because their reasoning is based primarily on pattern matching observed in their training data. There was also performance degradation with increasing difficulty. So the authors observed a consistent trend where performance decreased and variance increased as they increased the difficulty of the questions, measured by the number of clauses added or removed from the original GSM symbolic questions. All of this kind of, in conclusion, to skip ahead a little bit, the paper's basically arguing that current LLMs may lack true logical reasoning capabilities and instead excel at sophisticated pattern matching. And it basically highlights the need for further research and development in this area.
I thought it was a really interesting paper. It's fairly technical. I think if you don't have the background, I certainly probably don't have the background to discern all of the details here. But in terms of it, from an experimental standpoint, it was extremely robust. They used 20 open models, including state-of-the-art models such as GPT-4. And I think it really, again, highlights that the GSM 8K data set is probably not a good standard to test mathematical reasoning. One, and their introduction of this new GSM symbolic data set maybe moving forward is the best way to approach testing some of the mathematical reasoning abilities of these large language models. But also, I think more importantly is it does address this bigger question about what are LLMs able to perform this logical reasoning? And I think the answer, at least from this, is no. And that these models really are performing more likely probabilistic matching or pattern matching, given at least what they've demonstrated here. There's a lot more to this article than what we can discuss, but I think the take home really that the authors state in their conclusion is that adding seemingly relevant but ultimately inconsequential information to the logical reasoning of the problem led to a drop of almost 65% across all the state-of-the-art models. And so I think, again, this suggests, and the authors state this, that deeper issues in the reasoning process cannot easily be mitigated by a few shot learning or fine tuning of these models. So I think there's a lot to unpack here, and obviously we can't do that in 5 minutes, but really interesting kind of broad overview. And hopefully we haven't totally bored our listeners talking about this topic.
Yeah, no, I hope not, because I think we both find it very interesting, specifically, again, when these models seem to be so impressive and capable of so much that figuring out their limits as far as, applications is very important. And I think also maybe looking at the limits in our benchmarking, right? And knowing the tasks that we're giving these things, are they really useful for the tasks that we're going to be using them for?
Right. And I agree. And I think the authors also state this, and it's fairly, I think, obvious from what we've discussed so far, that the endpoint, which is creating human-like models or the end goal of artificial general intelligence, I think this paper demonstrates that we're potentially somewhat long ways from that.
Yeah, absolutely. If you wanted to feel good moment for those of you who are still worried about AI, I would think that this cinches the deal that, we have a lot more work to do.
That's for sure. And today we have an amazing guest on episode 8 of the Stat AI podcast, Dr. Rishi Khakhkhar, who is a practicing emergency physician and founding medical director of Counsel Health, which is an AI-enabled medical practice that specializes in messaging-based care. Rishi is also a colleague of ours from emergency medicine, and he has focused his efforts on innovating delivery of care with an eye towards developing high-quality, resource-effective, tech-enabled care models for providers and patients alike. His background is he obtained a dual MD, MBA degree from Northwestern University and also completed his emergency medicine residency at the Mount Sinai Elmhurst program, where he previously served as chief resident. It is an honor to have him on the podcast.
Yeah, absolutely. Rishi, I believe, is just a class behind me. Also served as one of our chief residents, extremely smart, polished, and future-thinking individual. So I know he's going to have some thoughts for us, and I can't wait to get into them.
Yeah, and let's just jump right into the episode.
Awesome. Yeah, first of all, Ethan, DJ, thanks for having me. Big fan of the pod. I'd consider myself a friend of the pod, so thanks for having me on. Oh, I'm an ER doc by training out here in the Northeast. Prior to that, I had been really interested in healthcare innovation, kind of got interested in medical school. And even before that in college, it was the time, like early 2010s, when it felt like tech was going to save the world. The social network had just come out. People were taking their first Uber rides, but that sort of innovation hadn't yet reached healthcare. There were some early sort of fledgling attempts in Chicago, where I'm from, and where I went to medical school, including an incubator named Matter that I spent a lot of time at, where you could hang out and watch what people were doing. But this sort of like health tech 1.0 scene was really nascent at the time. And it was clear that sort of like the technological advancements that had reached the consumer in the form of social media, in the form of payment processing and sort of other ways, like had not kind of reached us in care. And the healthcare experience was still kind of locked in a pre-internet, pre-cloud, pre-mobile kind of world. Fast forward to medical school, I was still hanging out at these places, but decided to go to business school to sort of put some more formalized knowledge around those structures. It turns out if you want to change something in healthcare, knowing how incentives work and how people get paid is really, really important. So spent some formalized time kind of learning about that, did a brief stint in consulting where I learned even more, and then came to emergency medicine residency where I promptly sort of forgot about it all. And that's a bit of a joke, but it got the advice that training was kind of the most important thing, number 1, 2, and 3, when you're in that setting. And I think that was some of the best advice I got during residency, was to put my head down and train at a really good center. But COVID-19 happened sort of smack dab in the middle of my training and upended kind of everything we thought about healthcare. And through flexibilities at the federal level and other things, made sort of creatively delivering high quality healthcare in places other than hospitals and clinics possible. And I got really interested in that idea, sort of taking an emergency medicine skill set or an acute care skill set and applying it virtually and in the home, which were possible sort of only for the first time in 2020 and 2021, when we sort of made some federal flexibilities happen. And I loved it. I thought that the innovations were coming out at like a really high rate at that time. And I decided to focus kind of exclusively on applying an acute care mindset to virtual and at-home care, and just like plop myself down in the spectrum of care, all the way from asynchronous care, which is sort of messaging based, to kind of traditional video telemedicine, through community paramedicine and hospital at home, which were 2 kind of care models that I was really interested in. And I decided like I would kind of do a fellowship in that mode of care. Like I would only care about that for the next 2 years of my career. So coming out of residency, I was lucky enough to lead virtual urgent care at our institution, which was really great. It was an amazing experience. Got to lead kind of an amazing set of faculty to deliver care, but quickly ran up against the limits of that modality. I thought kind of video was great for some things, but at some level, what we were doing is we're taking kind of like an average clinic visit or an average urgent care visit and trying to just put that itself in the cloud instead of reimagine kind of the experience altogether. And I got really interested in sort of either side of the spectrum, both like really high intensity care in the home, like hospital at home, and using sort of the most frictionless mode of communication that we have, which is text, and trying to deliver care with it. So ended up meeting the founder of Counsel Health in December of last year, a doc named Muthu Alagappan, who was starting this awesome new company around asynchronous care and needed someone to come and lead the clinical side of the business for him. And over the course of a few months, we decided it was a good fit, and I've been over here for about 6 months now.
That's amazing. I think a lot of emergency medicine physicians are always a little bit nervous about sort of jumping from the clinical space into the private sector and making that commitment to things outside of clinical medicine. I mean, that's kind of what we train to do. Tell us a little bit about what made you decide to do that and what sort of boundaries or limits you decided to put on that, and maybe talk about whether you had some fear in doing that or whether you're just ready to go for it.
Yeah, it's a good question. I think folks in emergency medicine look at careers sort of outside the ER. It's a tough career to do long-term. It's hard to work those shifts when you're 40, when you're 50, kind of like as time goes on, although they are still really rewarding. So some folks kind of jump into private sector gigs to escape, sort of like to go to something else, to not do clinical medicine anymore, but to instead like activate a different part of their brain, maybe work some more regular hours. So I don't sort of look down upon that way of doing things at all. I think some folks just need another part of their career, whether it's jumping into payer side of the world, pharma, startups, kind of like doing it in a non-clinical way. That was not it was not my motivation largely. Like I really like clinical medicine and I jumped into the private sector because I got an opportunity to do it at a level and at a scale and with some control and customization that I was not able to do in traditional healthcare settings. I found that over the past few years, especially the innovation in digital health has been such that if you want to deliver care in a brand new way, sometimes the easiest way to do it is to leave like large systems and other things like that. So I I wanted to double down on clinical medicine and do it in a more interesting way. And I thought this was the best way to do that. I still love like I still deliver care. I deliver care in our platform. I still deliver care in the ER. I think it's really useful for emergency medicine physicians to have their voice heard and to sort of like use their skill to kind of impact healthcare innovation in a bunch of ways. So it's more of a doubling down for me than a leading in any way, if that makes sense.
That makes perfect sense. And I guess I'm curious, kind of a follow-up to that is maybe you can walk us through what your day is like now versus kind of, I think we're all pretty well versed in like an EM shift. What's your current role at Counsel Health now?
Yeah. So I'm the founding medical director at Counsel. A lot of my day is meetings, as you expect. We sort of have to organize kind of how we're delivering value to customers. A lot of it is clinical too. Like I built for a couple of months, we didn't need this, but I built a clinical schedule. This is something you never really forget, and we cover clinically a handful of days a week. I'm sort of first call clinically on the platform for providers that reach out to us. It's almost more important to get that clinical time on a platform like this, where the actual care delivery of it is new, because when you work in a new modality of care, whether it's video, whether it's care in the home, whether it's something else, kind of feeling the texture of it and like, what does it feel like? And you can measure this with quality measures, but you guys definitely both know this of being in the ER. What is good care? Sometimes you just feel it. Sometimes you just know it. You know when you're delivering it. You know when something is making it so that you're falling short of it. And if you're going to lead the clinical side of a company, then I think it's really important that the texture of the care be started and sort of really felt by the leaders of the company. So I still am quite clinical. And outside of that, I try to make life as easy as I can for our clinicians. So building technology and the tools to make their lives easier and trying to figure out what quality care looks like in this form.
That's amazing. I'm not sure how much you're allowed to talk about, but can you tell us about what Counsel Health is aiming to do in terms of what sort of gaps it's looking to fill? And if you're able to talk about the platform at all in some detail, if that's so allowed, we'd love to sort of understand what the company is, focused on.
Absolutely. So you guys will understand this as docs when someone in your friend circle or family texts you with a medical issue, and then they give you some context and you're able to sort of like talk to them back and forth. They ask you for advice, or if you have a question that's specialty specific and you're like, oh, my buddy is a orthopedic surgeon for medical school. Let me ask him about my knee. Like he's the guy that will know. So Counsel Health is effectively that, but productized. So it's an opportunity for patients. It's an app that patients can use to text a doctor anytime and receive a response in just a few minutes, but it makes that care modality a little bit more robust. So not only can you get an answer from a doctor in a few minutes, but the doctor can write you a prescription, can order a diagnostic, has access to your medical records via health information exchanges, and is aided on the back end by sort of state-of-the-art AI technology to help that doctor respond faster, review records quicker, just generally be more efficient and more accurate.
That's amazing. I think DJ and I dream of that, sort of how that would fit within the framework of a larger emergency department or health system. I think that would just be an incredible tool and resource for patients.
Yeah, maybe taking a step back. We always like to start off kind of our conversations about AI by having our guests go ahead and define it for themselves. Go ahead and, if you wouldn't mind taking a stab, how do you define AI, I guess, in the context of healthcare first, and then for your new role?
Yeah, I think this is a big and hairy question. I think two main buckets are where I'd place AI in a healthcare setting. Number one is systems that use deep learning to become very good at a particular task, things that require deep pattern recognition, these old school kind of neural nets and this like more old school phrase of sort of deep learning. And examples here, I think, is Bayesian Health is a company that does deep learning around sepsis and the detection of sepsis using vital parameters and labs and other things over the course of a patient's hospitalization. Another is Viz AI that detects LVOs. So these sort of like deep learning systems that help us detect patterns that we might not otherwise detect. That's one, I think, bucket of AI in healthcare. And the other came about a little bit more recently with the advent of large language models. And it's essentially like LLMs that make life easier for healthcare providers, like a conversational chatbot that dynamically collects history, ambient documentation tools, chart summarization tools, the ability of these LLMs to intake large amounts of unstructured data and to structure it or to find something in it, or to even have full-on conversations like agents would, I'd put in that second broad category. So I think that's how I think of AI in healthcare.
How would you envision the biggest gaps in EM that AI might play a role? And I guess when we think of gaps, that could be problems too, right? At least right now, the hot topic would probably be boarding, overcrowding, throughput, things like that. But there are obviously other non-operational aspects that AI could potentially address. What do you sort of envision as, gaps that some of these technologies could fill?
Yeah, it's a great question. I think probably two areas broadly. Like, first of all, I think to approach like crowding and boarding, I think sometimes we look at technologies like AI and we expect them to solve problems that are like very political or organizational by nature. So unfortunately, like AI isn't a panacea. So I don't know how much AI is going to do about our boarding crisis. But I think one thing I'm really bullish on is the ability of AI to extend the power of generalists. I'm a strong believer in generalist medicine, not just emergency physicians, but primary care docs, pediatricians. I think the 30-70 split in generalists to specialists we have in America that we don't see in other countries is to our detriment. I think we underpower our generalists in lots of ways, and we feel this in emergency medicine departments, needing to rely on consults for X, Y, or Z, even though we love our consultants, versus being able to make kind of bigger decisions ourselves. So I think extending the power of generalists would be huge. And a couple specific ways would be in imaging. POCUS is huge, but all the advancements and sort of getting perfect echo or being able to highlight what you're looking at on either POCUS or plain film. There's plenty of ER docs around the country who don't have a radiology read first. So being able to extend our diagnostic accuracy for things that we do a little bit more rarely, like look at a rare extremity film or something like that. Another is making life easier for clinicians broadly, like things that make our lives better and easier. And I think probably the immediate first thing that other folks have probably said on your podcast too is ambient documentation. I'm a big believer in this technology for us. I think we spend way too much time in front of screens. So pairing ambient documentation with appropriate clinical decision support tool feels like a superpower to me. So I think those two things, extending our power as generalists and then making our lives just broadly easier. I think those are the two big things that I'm excited about with AI.
I couldn't agree with you more. I think the interesting thing for emergency medicine will be what form factor AI kind of takes to be that interface, whether or not it's going to be a wearable, probably won't be the phone, whether it's glasses, watches, whatever. There's a lot of ways that we can have kind of the ability to capture what's going on clinically already, right? Like already we have this ability. And so we'll see who ends up winning. I guess one of the questions along that line is that I'm curious about with asynchronous care, and I guess specifically what you guys are trying to set up here, how do you ensure appropriate triage for emerging conditions? You're extending the generalist, but sometimes things don't belong in the generalist. So how do you know when the cutoff and how is that being handled?
Yeah, I think this is a question that technology can help with, but really you need rock solid clinical operations. I think those of us who've worked in urgent cares or other settings know that you can put a sign on a door that says no emergencies, but people just walk in. When you have an on-demand care service, you're going to get whatever comes through the door. And that's great. This is the part about emergency medicine that I love, that you have to be prepared for whatever comes in at whatever time, and why I think our skill set is really valuable in these settings. For us, the answer is to always have a doctor in the loop. Still, we have a couple of AI history taking questions up front just to get a little bit more information, but it's very quick and a doctor is supervising pretty much the entire time. We don't have unsupervised chatbots talk to patients. We don't think it's appropriate at this stage for safety reasons and for other reasons, but I don't think we're quite there with the technology.
I'm really glad to hear you say that because I think Ethan and I secretly also agree we're not all there yet, but we don't have a company. So
yeah, I think this first wave or whatever you want to call it is we need to proceed with caution. I think it's a lot of these opportunities especially with asynchronous care and it just has to be designed in a thoughtful way. And we have to always, I think, hold true to the sort of emergency medicine principle, at least for acute care patients, that you're really sick until proven otherwise. So I guess that, our next sort of question we were thinking about is handling sort of the risks of misdiagnoses. How do you mitigate those risks, especially with high risk diagnoses that can potentially pop up with benign presentations?
I think that part of the answer to that is knowing the limits of what we can do via telemedicine. We learned a lot about this on video telemedicine, and over the course of a few years, we've gotten very used to what's safe and what's not safe to treat somebody on with video. We're going to learn the same thing with asynchronous care. And in fact, we already have, if you go on Amazon's website or use Row or Hims or one of those kind of platforms, we actually have 30 or 40 conditions that are routinely treated asynchronously in this country. It's not our first rodeo with this type of care. What's new about something like Counsel is making it a little bit more conversational and dynamic, advice-driven, and really allowing folks to ask whatever they want. So one kind of core safety kind of thing that we put up front is we have board-certified docs answer all the questions. So the first thing you need is that you need a clinical brain on the other side who's seen a thing or two clinically, has gone through those reps, gone through residency, has gone through those intending reps, and sort of knows what they're doing. The second is that there's a lot you can do even if you can't treat someone asynchronously, which is a fair amount of time. There's a fair amount of belly pain. You can't treat asynchronously. You can't put a hand on the patient. But after you risk stratify them, there's a lot you can do short of sending them to the ER right now. There's a whole bunch of in-between triage decisions that you can make for someone. And I think we have missed the boat a little bit in emergency medicine and triage by not owning this a little bit more up front. But the first triage decision a patient makes is when they go to Google on their phone and Google their symptoms. And that's what 88% of sort of initial health queries go to Google. And putting a physician or a medical group in that place in the decision tree allows you to impact a patient's care in so many ways. So let's say we make the decision, we can't treat you on asynchronous care right now. Are you okay to see your PCP in 3 days? Do we need to bring you to an urgent care right now? Or do we think the pretest probability of you having a catastrophic diagnosis is high enough that we need to bring you into an ER right now because you need the capabilities of an emergency department? There's a lot of subtlety there that we haven't quite teased out besides like very protocolized kind of care that I think it takes a doc to kind of guide folks along. But we have a lot of in-between steps between like, we got to treat you via text and you got to go right to the ER.
I think one of the maybe aspects of care where it might be okay to not have a full-on doc might be the after visit summary, like the aftercare. You've been seeing, you were given whatever medication or not given medication, given follow-up, whatever it may be. Well, I feel like having been a patient myself, dealing with family members, there's always lingering questions. And I feel like this may be an area for some sort of virtual agent. Curious about your thoughts on that. Do you see it that way? Or do you think that even kind of discharge process, you're long-term going to have somebody kind of monitoring over that?
It's a great question. I think there are studies on this that do automated texts after hospital discharge. I think the results are a bit mixed on purely automated texting. I think folks are wise to when they're talking to a machine a little bit. And I think this is going to get better.
Let me put you on the because I'm not talking about automatic texting. I mean, you can imagine 2-3 months from now talking to a frontier level model that has access to your information. I don't think anyone's going to confuse that for these touch tone follow-ups. I think we are kind of on the cusp of something different there. And if that's true, if it's not, then I take your point. But if it's true, let's go with that.
Yeah. No, I think it's a good point. It sort of changes the definition a little bit of what doctor fully in the loop means. If you're triaging an acute complaint, then you'd want a doctor there pretty much reviewing, at least our philosophy is we want people reviewing that immediately. If we're doing more of a routine sort of transitions of care check-in, I think that's totally possible that we set up conversational agents that collect information, that do med recs, that ask about things like, have you picked up your medication? Have you made your post-discharge appointment? And then a physician reviews that or a provider reviews that a little bit later. I think we live in a world where that's possible probably today. Our philosophy around sort of that type of care too, which we're interested in and we do, is that we still have to develop a relationship. So kind of like, it depends like who that agent answers to or comes from. For us, we believe strongly that if we're a medical group and we're creating a relationship with a patient who was discharged from a hospital sort of last week, it really helps them to know the providers behind the care, not just the agent behind the care. And because we're sort of new to that patient, we try to make almost like a synchronous attempt to contact them before we go to an async form of care. If you can imagine an emergency department though, like they've met that provider, they've interacted with that ED. So it's like that emergency department, that care team is who is following up on them through their care team member, who is this AI agent who's asking them how they're doing a few days later. I think it's an awesome idea. I think extending the reach of emergency medicine into those first few days post-discharge, especially higher risk discharges, is crucial. And the fact that we don't do so on a super regular basis is a problem for our field.
What applications are you using right now? What do you find to be, not that this is going to be an endorsement or anything, but what are you actually using in your workflow?
So there's like the async stuff and the ER stuff I've used and seen Viz AI. I think that technology is amazing. I think getting some of these deep learning algorithms to show me things that I'm not capable of seeing because I haven't done that deep radiology residency training or something like that is just the one, and I promise I'm not a shill for them, but the one that I'm so proud of our field and I'm so sort of proud of this technology is Steve Smith and Robert Herman and Pendle Myers and Powerful Medical, Paradigm. These guys, these ER docs, deep pattern recognition, but also just looking at patients in front of them. And this is like 15, 20 years ago, and seeing there was all these patterns on EKG that didn't quite meet STEMI criteria that were clearly having an MI in front of them. And they made up a new paradigm, one that made a lot more sense to them, and it called occlusion MI rather than ST elevation MI. And like the better part of 2 decades to sort of topple the paradigm that was there before, and now to receive this sort of acknowledgement in the premier cardiology journal of the acceptance of saying, like, we accept that you guys write about this. And it was EM that sort of really pushed the field on this. I'm just really proud of them. And what they did is they loaded up, over the years, they created lots of mathematical rules to approximate, okay, it's not a STEMI, but it's an OMI, but let's make like a mathematical rule that can approximate this. And a lot more recently, they learned that AI was really good at this. If you give AI like an amazing data set, it could start noticing when something was an OMI better than people could. This is not an easy skill. Emergency physicians who have been decades still miss these because they're really subtle. And this is one of I think the best and most amazing applications of this technology is like this incredibly deep pattern recognition that you or I, like on a shift, may or may not every time, but this tireless algorithm is going to pick it up every time. So that's probably my favorite AI and EM application is the one those guys keep.
There was essentially a paper put out by Apple last week that kind of calls into question whether or not LLMs are really actually using reason or just pattern matching. And, I guess it's kind of impressive, I guess, to say what you can do with just pattern matching alone, if that's what these things are doing, right? Maybe not. If the end goal is that, these things are passing Turing tests and people don't know that they're really conversing with a bot, then maybe not for the purposes of conversation. But when we're talking, clinical medicine, I think there is the hope that we can at least prove that these things have some utility to reason. And if not, then maybe we should not be using them at all. Yeah. And again, I think that remains to be, it's an awesome application.
Yeah. And kind of what you just kind of picking off of what you just said, I think when using these things in real life, actually taking care of patients, these conversational agents, I actually think the most useful framework that I use is a medical education framework rather than anything else. You guys will remember when you have a medical student on your team, afterwards you have to sort of rate them. And the sort of ratings it goes from reporter, which is, can you go factually report the truth, to interpreter, which is like, can you interpret exam findings and lab findings to get to a differential or to start doing some clinical reasoning, to manager. Do you have command over managing certain conditions? And I think part of the problem with sort of AI and conversational agents in healthcare is that we've expected them to be that manager right away. We're asking them to start managing medical conditions. Whereas I think, what do we know about teaching anyone medicine? You got to start them off on a fairly short leash. So I think we're starting in that first phase. Can you go report, accurately? Can you then interpret what you get back a bit more? And I think these agents deserve, more and more leash when they kind of prove themselves. And I think that's been the most useful framework for me.
I think you've touched on this already a little bit. I think it's a great topic of conversation, but how do you think maybe Counsel Health or AI in general can really shift to a proactive model as opposed to a reactive model?
Yeah. I think this is one of those places where I'm going to go back to incentives and the fact that technology sometimes can't solve administrative or organizational problems. ERs are reactive. We wait until someone comes to an emergency department, and then we treat them as best we can, and we discharge them. And if we do a good job, we check up on them afterwards. Our emergency departments, the way they're set up financially, are not incentivized to keep people out of ERs in the first place. And I think sometimes end up behind the eight ball because of that. And I think the solutions are more a rearrangement of incentives than they are sort of deploying technology at the right place, which could be part of the solution. But I'll shout out Dr. Hashim Zikri, NCSP fellow, former Sinai resident, who cares a lot about this too. And, I think it's long overdue for emergency medicine to get in the value-based care game and really show that we have skin in the game and show that we can do more than just treat strokes, but we can sort of like be hubs for the community and treat people the right way and get them connected to appropriate outpatient care and avoid marginal admissions, do extra to avoid someone being admitted to the hospital, and ultimately keep our communities healthy. And I think that's where emergency medicine needs to go in the next decade or two, not only for like the health of our, like the financial health of our community, but for the emotional health of our docs. I think, we're seeing a burnout crisis kind of wash up to us because we're not getting to deliver care in a bit more of a holistic way.
Radiology applicant and, future applications for counsel, when you're considering AI or what considerations are going in towards transparency, explainability? Are you putting an emphasis on that, or is that something that not like?
I think we have to with something like bias and AI. And then part of the reason is that a lot of the times these algorithms are truly black boxes. And something goes in and something goes out, and it's hard to tell sort of what happens in the middle. I heard recently about an example of an AI algorithm that was helping sort of like chew up orders in the ER, was disproportionately ordering abdominopelvic CTs for Black women rather than pelvic ultrasounds, because the training data that it was based on, Black women were going to places disproportionately that didn't have ultrasound coverage overnight. So they ended up having more sort of abdominopelvic CTs ordered rather than the ultrasound. We need to know about that. It's just something that it's not excusable if sort of like the output of your AI model has just internalized the same sort of biases that wash up to our shores in the first place. I don't have one silver bullet kind of solution to it, but every kind of AI deployment, I think, in the wild needs to be tested really, really rigorously for not just safety, not just are you getting the right answer 90 whatever % of the time, but be put through sort of sample cases or what have you to make sure we are aware of the biases in our algorithms.
Yeah, I mean, I couldn't agree more. I think, even if you were to ask me like what the training process is for a lot of the algorithms that I use, I'm like, they were, homegrown. It's very hard to find this information. And I don't think the companies have really, or vendors, let's say, have really, at least they haven't been made to come around to the fact that, transparency and explainability is really going to be a paramount issue. When a patient receives care by a physician who used AI, do we need to now disclose that? And if the patient can ask, okay, well, what was in that AI model? What do we tell them? Like, I think these are things that are on the horizon, maybe not too far away.
I feel like we always touch on generative AI and large language models. And I want to if you just give one take on how you think of using your favorite LLM in this context of asynchronous care and how it can advance the platform. Where do you see it going?
Yeah, I think there's a ton of directions to go. One, I think, is sort of chart summarization and pulling up relevant things. Like, the nice part about async is it's all text-based. So when someone sends you a query, you're not doing transcription, you're not like recording something and then sort of in real time, you just like have the text. So it's not that hard to then just pull up the relevant part of the medical record. I mean, it's hard. Our engineers spent a long, long time on this, and to do it well is really tough. But that's, I think, an immediate application is what's the relevant part of this person's medical record that will help me take care of this complaint the best. The one that Epic is rolling out, including us, is pre-drafting. I think we have to be a bit careful with pre-drafting because we bias folks. And what I'm talking about is the model takes the first shot at responding to a patient's query. This works well in some cases, doesn't work as well in others, but it really can kind of speed you up in the right context. Again, we have to be careful, but I think that's another one. One we're really bullish on is multilingual. These models out of the box are quite good. They need some work, but the ability for all of us have spent time on the phone with translators, and having this like third party in the room, even if you do it perfectly, makes the care a little bit different, to say the least, for you not to be the person kind of conveying feelings and to be conveying kind of medical information, for that to be coming from a third party makes things harder sometimes. Wouldn't it be amazing if you could speak to a patient in their native language, they could text you back in their native language, and you could seamlessly have this kind of culturally competent conversation? We're really bullish on AI to help us have that kind of conversation, and broadly for AI to unlock the humanity in the patient-physician relationship. Not sort of like hide behind chatbots, but to unlock sort of experiences that we've never been able to have before, to get closer to the heart of healthcare, which is really just a conversation between a patient and physician.
Well, thanks so much, Rishi, for taking the time. I know you're super busy, so really appreciate you taking the last hour to hang out with us, and looking forward to seeing what's coming down the line. Hopefully we get to meet up again in a year and see how far you've taken the company.
Yeah. Thank you guys. It's been a blast.
Absolutely. I really thank you coming here and giving a super nuanced take and just really taking the time to hang out with us. I really appreciate it.
Appreciate you guys. Big fan of the pod. So thanks for having me on.
Thanks so much for listening to episode 8 of the Stat AI podcast. We hope you can join us again next month for some more exciting and interesting content. Thank you again.
Please note that the views, opinions, and information expressed in this podcast are solely those of the individual speakers and do not necessarily represent those of their employers, our sponsors, or any affiliated organizations. The content provided is for informational and educational purposes and is not intended as medical advice. We encourage you to consult with qualified healthcare professionals for any medical concerns or treatment decisions. This podcast is not a substitute for professional medical advice, diagnosis, or treatment. Listener discretion is advised.